Tonight, our Elise Haas is continuing the series, Breaking the Cycle, Oregon's attempt at recovery.
Elise sits down for a roundtable discussion with 3 experts who are offering solutions.
Oregon has failed to address addiction and mental illness for decades. Today, that's evident in drug markets, tents, and RVs in neighborhoods. Now, groundbreaking research reveals the problem's true size. Join us as researchers unveil data for regional and statewide solutions. We're sitting down with Dr. Andy Mendenhall, CEO of Central City Concern. He's board certified in addiction medicine. We have Mindy Sadlander, CEO of Health Share of Oregon, and Jill Archer, VP of Behavioral Health at CARE Oregon. Thank you so much for joining us and for all of your work in this research. So to bring everybody up to speed who is watching, in the first part of your study, you guys really keyed in on 3 main groups: those with fentanyl use disorder, meth use disorder, psychosis, and a combination of the 3. And so to the outside world, public perception may be that those groups and numbers of those people have grown exponentially based off of what we're seeing on the streets. But what does your research reveal?
So what we found is that though the number of people on the Oregon Health Plan or Medicaid grew by more than 30% during the pandemic, the number of folks with a severe mental illness or a drug addiction grew by about 5 to 10%, depending on the condition. So what that means is we're not seeing a ton more people with those conditions, but rather those folks that have those conditions are much sicker than they were before. We think that's for 2 main reasons. One, we all know it was much harder to access care, treatment, counseling services during the pandemic. And second, the types of drugs are much stronger than they were several years ago, making both treatment more difficult and relapse more common.
So Andy, can you tell us how this is then playing out in what we're seeing on the streets?
Unfortunately, folks with untreated substance use disorder and severe mental illness have outsized representation among the houseless population, and in particular, the unsheltered population of folks who are homeless. And you know, it makes perfect sense that members of the community are asking themselves the question of what do we do with folks who have challenges caring for themselves, but then also the system of care doesn't have the necessary resources to ensure that folks have access to what they need in order to get better.
And speaking of access, you know, the second part of your study really focused on access to care, and you really did that by assessing and analyzing Medicaid patients and how they're interacting with the healthcare system in Oregon. And what you ended up finding is that people with mental illness and addiction are using the healthcare system, but in unproductive ways. For instance, overwhelming our community hospitals and our emergency rooms, which is both ineffective because they're not getting the right care that they need, but it's also very expensive for Oregon taxpayers. So what are you doing to try and use this information to break that cycle and address these problems?
So we understand the size and nature of these problems better, and that helps us figure out where we have gaps in our system and where we need to develop new programs that can better meet people's needs. For example, if we see someone in the who's getting treatment for schizophrenia in the emergency room, we want to get them connected to a care team that knows how to take care of that illness and support that person better. Same thing is true for someone battling a fentanyl addiction. We want to get them engaged in care and treatment early to hopefully prevent a longer-term bad outcome or an overdose. It's our job to make sure that the right people are getting the right care at the right time, ideally by providers who speak their same language and are from their same community, so that we can catch folks before they fall through the cracks. It's an approach that not only keeps taxpayer costs down and helps support hospital staff, but probably more importantly can save lives.
We also need to acknowledge that it is dangerous and difficult to withdraw from alcohol, meth, and fentanyl. And so we have gaps, major gaps in the system. Andy, can you kind of walk people through what a healthy behavioral health care system would really look like with all of those necessary step-down service to get somebody through recovery?
And what that looks like is people have the ability to get the treatment that they need when they're seeking it, and they can then be handed off sequentially each step of the way. So if we consider someone, for example, with a fentanyl use disorder and possibly a mental health condition along the way, there's really 4 core parts of their journey. The first is being able to access medical withdrawal management or detox for about a week. And then most folks actually would benefit from a residential treatment stay of about 30 to 60 days, followed up with a housing intervention and ongoing outpatient treatment services for substance use disorder, mental health, and primary care for about 6 to 9 months. Then on the back end of that, and we're proud our system drives these outcomes every day, folks get plugged back into workforce, they get job retraining, they re-enter the workforce and become sustainably housed long term. Where things are a bit more challenging is with a person, let's say, who has severe pervasive mental illness, let's say a diagnosis of psychosis with or without substance use disorder. And you don't have to look far in our streets to see people who lack capacity to care for themselves. Unfortunately, in our community right now, we do not have enough inpatient psychiatric beds, nor do we have enough secure residential treatment for those individuals to be stabilized long enough to be able to then benefit from a housing intervention and re-enter the general population and the workforce as well.
At this point, we know what those step-down services are. How do we fill those gaps?
We need to make sure we're making the right kind of investments, right? Either expanding existing services that we know are effective or building out new capacity. We're also investing both resources and technical assistance in creating more access points for medication for use disorders, which we know is very effective. So we're trying to make that available, very low barrier, in primary care, emergency rooms, inpatient hospitals, jails. Wherever we can get people connected, we're trying to do that, even virtually. We have that available over the phone, in fact. We're also investing in things like transitional housing so that if people come out of withdrawal management and can't get right into treatment, like residential treatment, we have several programs online or coming online where people can go for 14 to 30 days and have support, peer support, and other support while they're waiting for more services. What we're worried about is making people not trust the system and feel like it's not helping them if they go through a front door but then end up back on the street. So we're really trying to fill in those gaps.
And I have heard that when I talk to people on the streets is that trust is a major issue.
Yeah, and I think most importantly, together we're here today sounding an alarm. The reason we're here in our region is from 3 decades of underinvestment in the behavioral health system. And that has been made worse by the pandemic, an affordable housing crisis, and new, more dangerous drug supply. So we think we need to invest now to make sure that we have enough psychiatric hospital services, residential treatment facilities, and outpatient services, along with a well-supported and safe workforce to be able to provide that set of services to our community members.
And speaking of that, is the state at this point doing enough? What else is really needed for the people who are struggling the most with their mental health?
I think that there's great work that's being done. We feel that the behavioral health data that we're advancing is going to become foundational for part of a broader strategy, not only for the region, but we also hope for the state as well. We see people in our system getting better every day. People do get into recovery. People do get treatment and are getting the treatment that they need, but oftentimes it's after extended periods of waiting. And so we're excited to see alignment among key partners, and we're also excited that some design is being done regarding some scaled investments. And those scaled investments in higher levels of care really, I believe, will close many of the gaps that Mindy was speaking about earlier regarding the decades of underinvestment.
That's right. We think in our region we need around 200 to 250 more inpatient and residential treatment beds to serve people with a severe mental illness. These folks used to be served by the Oregon State Hospital, but now they just don't have access to that level of care to get that kind of support that they need. And also we need some of the newly planned investments from previous legislative sessions to come online, especially to serve those folks who need 24/7 care. And that's both youth and for adults.
That's right. And if we're going to have all these new services come online, we need probably on the order of several thousand additional certified addiction counselors, recovery mentors, master's level clinicians to really provide these new services. And we need people from the communities that we serve. So we really need to invest in a culturally specific and diverse workforce.
Hundreds more beds and thousands of more clinicians. So those are, big numbers, but helpful to have. So now moving on to some final thoughts, from each of you. What do you have to say to the people of Oregon who have been impacted by the effects of untreated mental illness and addiction? inside their families or right outside their homes, schools, and businesses?
Elise, we know that hurting people are and have been harming our community. It's a really difficult statement to make, but it's our truth. And to your point, this is impacting families across our region and across our state. It is impacting businesses. It's tragic that we're making national news because of these challenges more broadly. And people are tired, right? There's a ton of stigma, and people's ability to be compassionate is I think, at an all-time low. All of that said, I'm really hopeful. There's always hope for people who are hurting, and I believe fundamentally that this data strategy and the level of partnership that we're seeing between our regional healthcare providers, regional government, and state government, that alignment is actually creating a foundation for us to really create meaningful change.
I am heartened by the level of partnership across all these different types of stakeholders. I think it's really going to take, this is a big complex problem that took a long time to get into, and it's going to require a big complex solution to get us out of, and that means everyone from the business community, healthcare providers, insurance plans, coordinated care organizations, working together to make sure that we can respond.
And I would just say, I think we need to keep having these conversations in our communities. And that recovery is possible. We know it. I mean, Andy lives it every day.
Andy, Mindy, Jill, we are incredibly grateful for you joining us and for your commitment and dedication to try and help resolve these crises for the people of Oregon. It's deeply appreciated.
Thank you, Elise.
Thank you.
So the team has continued working on their study, and they have since found that homeless people with a mental illness, fentanyl or meth use disorder, go to the hospital 12 to 14 times more. So you can see the impact on our healthcare system there.
And the fact that Andy brought up, it's not just one thing, it's detox, then residential treatment, then maybe permanent housing or some kind of housing. And Multnomah County's been so stuck on maybe permanent housing, and then detox got defunded. We didn't have detox. It takes several things together working in unison to have success and solutions.
Right, and our biggest gap right now is in that secure residential treatment and then also that supportive housing. So, of course, you can't go from detox back into real life. That's not how it works.
No.
It's going to be much longer than that. And so, these are real lives that are at risk, but they're also impacting lives, around us too. Right. This is one of Oregon's greatest challenges, and it can't be a guessing game, right? No. It shouldn't be a guessing game.
You need this data that they're collecting.
Good data matters.
And that formula and work with it. And it was key to hear how, yes, it's also finding the people who can help, who come from those backgrounds. We're talking languages, cultures, ages, who understand one another. Then they can help people even more and connect them so that they gain that trust. Powerful reporting once again, Elise, a discussion that we all needed to hear. But I want to remind everybody that's not all. This is a multi-part series. It is once again called Breaking the Cycle, Oregon's Attempt at Recovery. It continues on. You'll recall voters here in Oregon approved Measure 110. It decriminalizes certain amounts of drug possessions. Well, the shortcomings do get a lot of attention with that measure, but what about the benefits you don't get to see with 110? Next Wednesday at 5, Elise looks into where your money is going and how it's starting to help people.